whenever you're ready.
Hi everybody, my name's Jo Senior. I'm one of the obstetric doctors working here at Northumbria, and I'm here today to talk to you about assisted or instrumental births. Now, most people don't think about the fact that they may require an instrumental birth, but about 15% of women will need a little bit of help getting baby out, and that is goes up to about 30% with first babies. So it's something that's really important that you're aware of before you come in labour. So if you've got any questions, if you need any more information, you know who to ask and where to go. So I suppose the first thing is, what is an assisted birth? So assisted birth is where we use an instrument, usually the forceps or a suction cup, to just help baby, gently guide baby through the pelvis and out into the world. There are several reasons why we might be discussing assisted birth with you. One of them is if you've been pushing for a really long time and you've gone through a kind of long labour or a long second stage of labour from full dilatation. That's when we might kind of have a discussion with you about whether you want to have any help with delivering baby. Sometimes babies are showing signs of distress and we're worried about the amount of oxygen that they're getting in their second stage, so that's another reason why we might discuss having an assisted birth with you. And sometimes some ladies are recommended to have an assisted birth because they've got medical problems that means that they shouldn't be pushing for a long time. So I guess you're probably thinking, do I have an option? Yeah, of course you do. Of course you have an option. We will always discuss with you what the alternatives are. Generally, the alternatives are either carry on pushing for a longer amount of time or going for a caesarean section. There are obviously risks to any sort of birth, the normal birth, assisted birth, or full dilatation caesarean section, and that's something that we will discuss in a few minutes' time. I'm not going to show you the instruments just yet. I'm going to leave that until the end so that if anybody doesn't want to see them, you can go off and make a cup of tea and come back once we've discussed all that. So we'll talk a little bit about kind of what happens during an instrumental delivery, just quickly. If we get to the point of your labour where the midwife who's looking after you thinks that you might need a bit of assistance or that it should be discussed, they'll get one of the doctors to come in, who will obviously introduce themselves, have a quick chat to the midwife, have a feel of your tummy, see how far down baby's head is, and then normally do a vaginal examination to see how far through the birth canal baby is, and also which way baby's facing. That generally gives us a better idea of which instrument we should be using. Now, if you have an absolute aversion to one or the other, to the forceps or the suction cup, then please let the midwife know when you first come in labour, and the obstetrician will then have a chat to you about that. Often we would choose one or the other because clinically we feel that it's more likely to achieve a successful vaginal birth. It all depends usually on these little people. So what we're looking for is which way is baby facing. So have they got the head nice and flexed and tucked down and facing the right direction and facing down towards your bum? If they have, then often if they're nice and low down, we can use a suction cup. Sometimes if they're a little bit higher up or there's a bit of swelling on the top of the head, we might choose to use the forceps instead. Sometimes they're being very awkward, facing up the way, and the diameter of the head that's trying to come out is a bit bigger. So sometimes we need to either use a suction cup to turn baby round, or sometimes we can use forceps to turn baby round. And that is something that your obstetrician will explain to you once they've done the examination and figure out what's going on. Now, we sometimes do instrumental deliveries in your delivery room. Sometimes we do them in theatre. And again, a lot of that depends on which way baby's facing, and also how much pain relief you've got on board. And often you will have an option to go to theatre to have more pain relief if you feel like you're going to need it. In terms of pain relief, there are three things that we generally use. One, if you've got an epidural on board, that's great because you've already got the pain relief there. Sometimes we also use local anaesthetic, which is similar to the stuff that they use at the dentist. So it makes everything nice and numb, but it and doesn't take away the kind of pressure, and it doesn't take away any pain that you've got from contractions. We put injections into the perineum, which is the bit between the vagina and the back passage, and also to try and numb the rest of the labia and the vagina. Sometimes, especially if you've been pushing for a very long time or you're really tired, the doctor might, even if baby's facing downwards, and in theory we could deliver baby in the room, we might also offer you the option of having a spinal anaesthetic, which makes you nice and numb from armpits down to toes, so that you've got better pain relief on board. Again, this is something that we will talk to you about and give you all the options for. So it's really important that you are all aware of the potential risks to you and to baby of having an assisted birth, and also, if you choose not to have an assisted birth, what are the potential risks of carrying on pushing or having a fully dilated caesarean section. So almost always with forceps deliveries, and about 50% of the time with a suction cup delivery, we will give you what's called an episiotomy, which is a little cut that goes from the back of the vagina out towards the right hand side, and that's to make a little bit more space and to prevent you getting tears that go to the muscles around the back passage. Those kind of tears can still happen. They're called obstetric anal sphincter injuries, or OAC for short, and if that happens, we will tell you and obviously repair it appropriately. We always try and deliver baby's head nice and slowly, so the doctor will talk you through when they want you to give big pushes and when they want you to give little pushes and just breathe. And we also protect the perineum to try and prevent those sort of tears happening. Tears are more likely with forceps deliveries than suction cup deliveries, but the forceps deliveries are more likely to be successful than suction cup deliveries, so it's a bit of a balance. In terms of risks to baby, they're almost always, if you use a suction cup, they almost always have a little bit of a swelling on the top of their head. That's really, really common and starts to go down within the first couple of hours and is normally gone within 24 to 48 hours. Other than that, with suction cups, there is it's like I said, it's a higher chance that they don't work, and also there can sometimes be some bleeding around the underneath the skull, between the skull and the brain, so we just keep a close eye on baby for a couple of days, but that is really rare. With forceps, they almost always have a little bit of bruising across the face. Again, that goes down really quickly. It's not something that tends to cause kind of long-term problems, but there is a nerve that runs across the cheekbone called the facial nerve, and sometimes, rarely, but sometimes that can be damaged. If it is, sometimes babies might have a little bit of difficulty in feeding, but generally they get better with time. We also sometimes use what we call Keelan's forceps, which are forceps that can turn baby round, and there's sometimes suction cup where we use a suction cup to turn baby round as well if they're facing not straight down. With the Keelan's forceps, they are actually more likely to work than a rotational suction cup delivery, and they also actually have been proven to cause less trauma to both mum and baby than a rotational suction cup delivery. But there's a lot there's a lot kind of out there at the moment about whether we should or should not be using them. As long as they've been used by the right person and an experienced person, they're really safe to use. So sometimes we might need to turn baby round, and there's 3 ways that we can do that. We can either use a suction cup, forceps, or sometimes we can actually manually turn baby round. Now it's more likely to work if we use forceps than suction cup, but again, it tends to be up to the person doing the delivery or the obstetrician as to which one they think is going to work better. In terms of if you decide to go for a full dilatation caesarean section, they are more risky to both you and baby than if you have a caesarean section earlier on in the labour. That's because of the positioning of baby, and sometimes it can be quite difficult to deliver them abdominally if they're already coming through the birth canal. But again, your doctor will talk to you about that if it needs to be done at the time. So after baby's born, If you've had a tear or an episiotomy, obviously there will be stitches, and we will recommend that you take regular pain relief. We usually use paracetamol and ibuprofen, and sometimes something called diclofenac or codeine. It's important that you try and stay as mobile as you can, and that you take regular pain relief. Don't wait for pain to get bad before you take something for it. Sometimes if you're having stitches done and things, the first feed can be a little bit delayed, which often concerns some women. But we recommend that you do skin to skin. There's absolutely no problem wherever you are, if you're in a delivery room or if you're in the operating theatre, with you doing skin to skin, and your midwife can support you through that. You can feed as soon as you want to, as long as you're comfortable to, that's absolutely fine. In terms of future pregnancies, having an instrumental delivery or an assisted birth in your first pregnancy actually increases the chances of you having a spontaneous vaginal delivery next time, versus if you have a cesarean section when you're fully dilated. So that's something to be aware of as well. So in terms of feeding baby, if you do have an assisted birth, as I said, sometimes it can be a little bit slower to get the first feed, so it's really important that everybody considers their colostrum harvesting from 36 weeks, and your community midwife will go through that with you and give you all the equipment that you need to do that. So if you've done that, brilliant. I suppose everybody's probably wondering how you can avoid having an assisted birth. Sometimes genuinely you do absolutely everything you can, and there's baby's just not playing the game, and we then need to have that discussion with you. The main things you can do is have somebody who's there to support you all the way through labour, and that's the thing that's been proven to work the best in terms of avoiding having an assisted birth. So having a really good birthing partner is really, really important. Other things are moving around during labour, so stay as mobile as you can. Obviously, if you have an epidural in, you can't really get up and walk around, but try and stay upright during labour and when you're in the second stage, and when you're pushing, stay either upright or on one side or the other. And that's the same if you don't have an epidural, stay upright or in what we call lateral position, so laid on one side or the other. As I said earlier, you do have the option to say no, and this is always a discussion, so please don't come into hospital thinking that you're going to be forced into doing anything, because you're absolutely not. It's always your choice, and we will just discuss things with you. If you have specific things in your birth plan, just make sure that the midwife looking after you in labour is aware of that, and they will pass that on to the obstetric team. I'm going to actually get the instruments out now, just to show you how they sit on baby's head, and so you can have a look at them and see kind of what we might be dealing with. So if you don't want to see them, that's absolutely fine. Go and have a cup of tea and come back in a couple of minutes. Okay, so let's go through a suction cup first. There are two types that we use. One is a metal one, but more commonly we use something like this, which is called a Kiwi. It's a handheld suction device, and it sits just on the flexion point of baby's head back here, and then whoever's doing your delivery pumps up the suction. It's not going to work because it's not a proper baby's head, and what we're aiming to do is gently just flex baby's head, and we just gently guide baby out. Okay, so that's the suction cup. Like I say, they do form a little bit of swelling on the top of the head, but something that goes down very quickly. Now, these are forceps. They look like giant salad servers, and they tend to clang together. We do try and avoid them clanging together when they're in the room with you. They have a curve that goes that way, which goes with the contours of your pelvis, and a curve that goes that way and sits around baby's head. So when we put them on one at a time, and they just sit just like that. Okay, so they're not gripping baby's head, they're not squishing baby's head, they're just helping again to flex the neck and to guide baby out. Okay, so that's why they sometimes get the bruising on the face, just because of where they sit on the face. Okay, again, I'm not going to go into much more detail about that, because you can ask those questions as and when you come into either antenatal clinic or when you're coming in labour. If anybody wants any more information, just let your midwife know, and the Royal College of Obstetricians and Gynaecologists has a really good patient information leaflet about it as well.